Shaf, thank you for joining us. As you know, this is part of the History and Archives project, and we're kind of interested in your insights in terms of Toronto, the history of transplant, where you think we're going. And let's just start off with, what are your first memories of transplant at the University of Toronto?
It's sort of an interesting story. Actually, I remember it to this day. I was driving across the Mount Pleasant Bridge in Toronto, and I heard on the radio that surgeons at Toronto General had transplanted a lung in a patient successfully. I was a medical student at the time, and I remember just sort of reflecting that that's pretty cool. I didn't know lungs could be transplanted, or I didn't think of it as a thought. You know, you'd heard about kidney transplant and heart transplant, and I thought that was kind of cool. And then that was sort of a passing thought, and I continued on in medical school. And then when I got to Toronto General Hospital, I got assigned to the thoracic surgery service as a junior resident. And I was working with, Griff Pearson, Joel Cooper, Alec Patterson, Tom Todd, and really, learned about what thoracic surgery was for the first time. But at that time, they had just started doing the single lung transplant. And one night, they were setting up to do the first double lung transplant. And I was a junior resident on the service and got to participate in the operation. And it was just fascinating to be part of something that hadn't been done before. Obviously, they were all involved. There's a huge crowd of surgeons involved in it. But it sort of opened my eyes to the fact that they were doing something totally new. This has never been done successfully before. And, to be part of that was incredibly exciting. And then I sort of realized in looking after the patients after that how early days we really were in lung transplantation. The patients were so incredibly sick, so challenging to look after. And in Toronto, we have the surgeon scientist program where you can go into the lab and get your master's or PhD in surgical investigation or science. And I chose to do my work in lung transplantation with Joel Cooper. And when we were looking at projects and so on, at that time they were preserving lungs with cold atelectatic immersion. So they'd put a bronchial blocker down, collapse the lung, and then fill the chest with ice saline. And that was the preservation technique in the operating room next door to where the recipient was. And, every time we did a lung transplant, a member of the surgical team would sleep in a bed next to the patient in the intensive care unit, and we'd take 12-hour shifts for the first 48 to 72 hours because the patients were so sick with rip-roaring reperfusion injury that we had to be right at the bedside fiddling the drips and managing them. So it was, it was an exciting, interesting experience in physiology, but you realize that we've got to get better at this. So in looking at the projects in the lab, Joel said, we got to figure out lung preservation. We got to figure out how to do this right. And so, I studied all the literature and looked at all that had been done, and I realized that everything had been directed to the kidney, in terms of how to preserve kidneys. And Fujimura in Japan at the time had been going in sort of an opposite direction towards extracellular solutions and looking at the microcirculation and working with things like dextran and so on. And so we decided to design a solution for lung. And, key factors were low potassium and something to address the microcirculation of the lung. And I hypothesized that the real vulnerable problem with the bronchial anastomosis was not just the technical factor that bronchi don't heal well, but that we don't preserve the microcirculation, and that the retrograde circulation to the bronchus was part of the problem that we were having technically. So we developed the low potassium dextran solution, and I started doing, it was dog experiments at the time, and comparing it to urocolins, and which was clearly better than atelectatic immersion. So we at that time, then I convinced Joel and Alec to switch to flush preservation because it was still better than allostatic. And we started flushing lungs with urocolons. And as the person in the lab and the only one who knew how to flush lungs, I got to do that and take some of the senior surgeons along to Mel Goldberg at the time was doing that, and we introduced flush preservation. So you can see how I sort of grew up in an era where things were changing, we were still trying to figure out and clearly trying to do it better. And then in the dog experiments, we realized that the low potassium dextran was far superior, and that we could actually preserve lungs in a more reliable fashion, and not have that sort of acute lung injury. And we studied the issues and how potassium would affect the microcirculation, and the importance of the dextran in the solution. So we then started making it at the Toronto General Hospital. My wife Donna actually taught me how to make it in the lab, and we used to make it for the clinical program. And then our pharmacy got into making the low potassium dextran, which is now, subsequently was marketed by a company in Sweden and is sold as Perfidex. But what that also really showed me was that really exciting opportunity that you find a clinical problem and you go and solve it in the lab, and with persistence you can actually make a difference. And one of the things that I'm incredibly grateful for to Joel and Alec is having introduced me to that culture of investigation, discovery, but being able to bring it back to the bedside. And Toronto General Hospital is a remarkable institution for that. I mean, we used to make our own LPD at the time, and then they said, well, okay, well, maybe the pharmacy ought to do it, and for a number of years, our pharmacy made our own solutions until it was commercially available. And it was sort of the same spirit in which that institution allowed Joel to try lung transplantation again when it had failed in so many other people's hands so many times over, that he had done the basic science work, done the preclinical animal work to say that it was a reasonable risk to try it again in humans, and the institution has been very supportive in that way. And over the years, as we've continued to try and push the boundaries in who we can offer lung transplantation to, and how to make it better in terms of utilizing more organs safely, it's been a very rewarding experience and an enabling place to be able to continue to push the boundaries. And we crossed a similar threshold with the development of the ex vivo lung perfusion. So certainly, Stig Steen is to be credited for, revisiting the concept of ex vivo lung perfusion. I mean, that's not a new concept. There are drawings. Leonardo da Vinci has drawings of organ perfusion systems for hearts and kidneys and so on. And Charles Lindbergh tried to do it as well. He had an interest and worked with Alex Carrel doing that. But many of us have failed in doing that. And Stig said, you could use this to assess a lung and see whether the lung could work. And he was interested, as you know, in the DCD donors. But I really saw this as an opportunity to go way further than just assessing a lung. That's saying, can we actually repair organs? Can we take organs that are not good enough and make them better? Can we make organs better than the way we find them and immunologically prepare them or make them more like self? So if we're going to do that, the ex vivo technique really is the platform to do whatever you want, not just assess the organ, to repair the organ. And I had been working on that concept of genetically modifying organs for many years, looking at gene therapy to improve the early and late function or performance of the organ after transplantation. And I saw the ex vivo platform as the way to go in whatever repairs that we dream up in time to go. So when Marcelo Sipel came into the lab, I sort of said the same thing as Joel had said to me, that Marcelo, we've got this gene therapy thing figured out. I think it improves the organ. The IL-10 gene therapy is a key modification to the lung that we can do, but it's just not practical to be flying all over North America with a vial of adenovirus to put into a donor, and we don't have time to fix things and wait for it. So we have to figure out how to do this ex vivo. And when you keep a lung outside the body at cold temperature, it's metabolic processes are shut down, and so the lung is shut down, and the ability to transduce a gene is shut down, as you know. So you really need to be able to bring it up to temperatures where metabolism can work again, and gene incorporation can be carried out. So we set out to develop an ex vivo system that could be stable enough for a period of time to be able to do advanced repairs. So assessment, but repair of organs, and ideally assessment of your repair. And, we worked for, probably Marcelo sort of worked for about 9 to 12 months of, just basically failing each time. I mean, we were trying with blood perfusion, with different concentrations, varying hematocrits, temperatures, different kinds of circuits. And ultimately, we hit on a system that appeared to be perfect for what we're trying to do at this point. And I remember the day when Marcelo called me. He said, I've got a lung on, and it's now going on 9 hours. It's been on the circuit, and it looks normal. And I came over to the lab, and you know what a lung looks like when it's turning bad. And this is a lung 9 hours on the circuit and looked like a normal lung. I said, we got it. We find, I think this is big. And it really was. It was probably one of the most exciting moments in my career in investigation, because this is something I never thought I'd see in my lifetime. I've watched lungs deteriorate on isolated lung perfusion preparations for decades, right? So to see this at 8 or 9 hours, I knew we'd hit onto something pretty significant. And we moved pretty quickly to do the survival experiments in animals on that. And all of the animal experiments bore out well, and we realized that this was going to be an opportunity in the early time to just be able to assess the lungs that we and others are turning down and use them safely, but again, a step towards the ultimate in terms of repairing and engineering lungs. And so we continued to move the process forward, went through our IRB at Toronto General Hospital, and again, remarkably, they sort of looked at it and they said, "You're doing what? Like, you want to do what?" But we showed them the data and showed them that you can take a lung outside the body, keep it at 37 degrees, and actually improve it and have a better result after transplantation. And then we went on to do the big trial that was published in the New England Journal. Again, that was, for Marcelo, the opportunity to bring his research project to life and to translate it into clinical application. And the institution supported us tremendously in terms of being able to do it right and do it carefully and safely and with the appropriate way, so that we could change practice. And not only that, we were able to create the data and the process to actually get it approved by Health Canada, working through the FDA as well. And also now it's actually a reimbursable procedure, so going right from concept to standard of care, we were able to take that the whole way. And I do believe that will be a transformation in the way that transplantation is performed. Not just lungs, but I think all organs. And I think Peter Friend's success with ex vivo liver perfusion a couple months ago is that coming to fruition, that we'll be able to do this with all organs as each of us work and find out what are the specific needs of each organ in that specific situation, and also personalize the treatment to the specific injuries for each organ.
Chef, Toronto has had obviously a long history and a tremendous importance in terms of not just innovation around lung transplant, but also training probably more of the practitioners in lung transplant than any other institution. Can you just talk about, how it came into that role, what it is about the culture and the climate, and what are some of the proudest moments that you have around being able to bring this to all sorts of different places?
Toronto has a great history, as you know, in thoracic surgery, and one of the things that I feel has been very important is the culture of mentorship and achieving excellence or striving for excellence, and really focusing on developing thoracic surgery and continuing to look for ways to improve outcomes, and not only transplant, but in cancer and other thoracic surgical problems. And really our sort of core DNA has been sort of what's next, what not being satisfied with the status quo. And they, I think it started with Griff, Griff Pearson has this incredible, almost childlike curiosity to this day of just why, how come, maybe we can fix things this way. And the ability to pull together and recognize the fact that none of us do what we do alone. We stand on great shoulders, and even our achievements that are attributed to us are really attributed to the team. And people understand that. And that has built a culture where everybody is sort of clearly stronger than the individual and thrives on the success of the team. I think, that sort of a place then attracts the best talent. It's not like the talent all grew in Toronto. People came to Toronto to train, to learn the Toronto way, and I think, certainly Joel and Alec took some of that to St. Louis and continued in the spirit that they had been brought up with in Toronto. Bob Ginsberg was a major force in terms of mentorship of students, of paying so much attention to the next generation. Truly believing that the person you're teaching is probably going to do greater things than you've ever done, and putting them in a position to believe that themselves and strive to do that. I think that is a unique aspect of it. The other thing about Toronto is, and I don't underestimate, is institutional support. I guess thoracic surgery earned it by doing great things and having a sort of global footprint, but the institution is very supportive of thoracic surgery and of leadership and global impact. So that sort of, again, is an enabler that allows us to get far more done than you'd expect for the resources or for the immediate environment.
Can you give a little more insight in terms of what it was like with Joel and Alec, and what the actual kind of climate was like, and any amusing stories that you might have about the beginnings?
Joel is an interesting story in persistence. He's probably one of the most innovative and intelligent human beings that I've ever met, and I certainly benefited tremendously from being trained by Joel and mentored by him. And Joel was one of those taskmasters where he expects perfection from you. You can do 99 things right. The one thing you do wrong, he'll just rag on you for hours about the one thing you should have got. But on the other hand, if you strive for excellence, you understand where that's coming from. The other thing that I value tremendously from what I learned from Joel is persistence. And I knew that, when we were developing LPD, we had a couple of animals that just had spectacularly good 12-hour preservation and so on. And then the experiment stopped working, and for months it just didn't work, and I couldn't figure it out. And Joel said something very important. He said, if you've done it once, you know it's possible. We just need to figure out how to do it every time. And we did. We sorted out the problems. We found out what had gone wrong with the experiments, and we changed how we did it and totally solved the problem. The rest is history. But it's a really important lesson. And when we look in transplantation, we all have these situations where we've seen a patient who's achieved tolerance, or we've seen a patient who, you didn't expect to survive and you pulled them through this time, If you can do it once, we just got to figure out how to do it every time. And that's been a very important lesson. The other part was persistence. 40 attempts had been made at performing lung transplantation, and they all failed. But Joel just believed that it could be done, that it could be done. We'll figure it out. So those were important lessons. Then you come to working clinically with Joel, and that's a different story because, at the time he'd done the work in the lab showing that steroids were impeding the bronchial healing and so on. I think it was all preservation and microcirculation, but anyway, they thought it was steroids at the time, and so they didn't give steroids, in the perioperative period. But, so it was all in agreement that the team would look after each patient, and they'd meet 2 or 3 times a day at the bedside. And I was a junior resident in the ICU, and Ron Grossman and Joel and Alec and Wolf DeMaio and the early Tom Todd team would meet at the bedside, and they'd agree what they're going to do. And then 4 hours later, 11 o'clock at night, Joel would come by and give the patient a bolus of steroids, right? And they'd all agreed that they weren't going to give steroids, and it was a bad idea, but Joel just kind of thought it looked like rejection, and he'd give the steroids. And so half the people didn't know what went on half the time. So, that used to infuriate them too, because they'd made a decision together. But again, Joel was a very good clinician, and he, kept in touch with every detail of the patient. And I think he was probably right at the time, in terms of the patient probably did need steroids at that time. But those were the kinds of things that sort of drove everybody crazy from that point of view.
You obviously inherited the first, the program that initiated it. There's always this an interesting transition of if you've done something very early on, you have a lot of anecdotes that end up being how you practice.
Yeah.
And they can be actually historical anvils on you.
Yeah.
You've obviously been able to shed the anvils and move forward. Can you just talk about some of the challenges of moving from the very beginning to make sure that you're constantly in evolution and leading?
Having grown up in Toronto and trained there, after I completed my training, there's nothing more that I wanted to do than be director of the Toronto Lung Transplant Program one day. And as you know, in the late 80s and early 90s, Joel left and Alec left and Tom Todd left, and before you knew it, there was nobody there anymore, and the program was really severely threatened in its existence and had really dropped a fair bit in volumes and productivity. In fact, the lab, which had been about 20 people or so when Joel was there, was down to 2 people in the thoracic research lab. So, that was a very difficult time and an unsure time for me. I'd sort of trained to do lung transplantation, and I wasn't even sure that Toronto was going to be there anymore. But again, I had faith in the institution and had, I guess the courage to think that we could turn it around. And came back to start to do it, and obviously recruited Tom Waddell and other people that made us the strong team that we are today. But there was that issue that it's a big weight on my shoulders. This is the Toronto Lung Transplant Program, and it was faltering badly, both in many areas. And I knew how important in lung transplantation the research laboratory program was to moving the field forward. It was still early days, and then the clinical program was faltering. And then there was also the issue of, like you say, that this is the way it's always been done, and yet as the science was developing and things, I was recognizing that, that wasn't necessarily right. You know, the new information came out and new ways to practice, and we just couldn't be stuck in our ways. So I've always been open to new ideas, even though as a clinician you want to do what's safe and what you've always done, you have to recognize that this is a field that we haven't got it all figured out, and we are going to be changing a lot. So we instituted the Toronto lung transplant retreats. Once a year we take the whole team, the entire team off-site, and we do it close to Toronto so people can get back if there are patient needs, but try and get everybody in the room together and sort of talk about issues. We look at our results. We look at how we practice and say, you know, does this immunosuppression make sense? I know it's the way we've always done it, but in view of current evidence, are we doing the best thing? Are our results the best in the world? Are they as good as we can make them? And with that sort of honest view with all of our students and our nurses and our residents and all our colleagues in the room, we can sort of, we've always had the environment where someone could say, well, you know, that really doesn't make any sense to be doing that, even though that's what we've always done. And that gave us the courage to change things and implement change, and then look at it, you know, come back a year or two later. Since we changed certain things, have we had an impact? Has it been positive or negative? Usually positive if we've thought it through well. The other part too that we're very fortunate about in Toronto is we get many visitors, you know, from all over the world coming to see how we do lung transplantation. And another thing that Griff always taught us is we learn as much from the visitors as they learn from us. And so there's no shortage of people coming through that do things differently, you know, or have grown up in different places. And so we've sort of been certainly blessed with those opportunities of a lot of bright people coming by and saying, well, this is the way we do it, and or a different way. And so we've always got our eyes open to good ideas.
Shaf, you were involved in what is kind of a famous surfer girl case, the 13-year-old who was dying of pulmonary hypertension, and was the first real utilization of the technique of sewing onto the pulmonary artery to left atrium using the Novolung. Can you tell us a little bit more about her or other fun stories that you have in transplant?
Yeah, Surfer Girl was an interesting story. She's a young girl, I think she was about 13 at the time, with primary pulmonary hypertension, and she was dying and having, you know, literally drop attacks with her pulmonary hypertension. I think probably one of the most enlightening thoughts I ever had was the idea to put the Novolung from PA to LA, because conceptually it made sense, but that's a remarkable story because I just wasn't sure that it would work, that it would be the right thing. But, you know, we had a chance to talk to her parents, and she was in a desperate situation, and so we all agreed that it should be done. And that was, again, another story of innovation, change, taking some risk. And she actually arrested, so we were doing CPR and put in the Novolung in the less than ideal situation. But it turned out to be a wonderful story because, you know, we proved the concept that was an ideal way to bridge patients with primary pulmonary hypertension to transplant. But also, you know, not only that, she ended up having a remarkably good result, got out of hospital, and that famous picture is her surfing in Hawaii 6 months after her lung transplant. And she's since gone on to graduate from college. So, I mean, it's just one of those examples of what makes what we do such an exciting career, to be able to do things like that and get people back to a meaningful life is really a remarkable opportunity and privilege.
Agreed.
But the other funny story, I told you I was there for the first ever double lung transplant. So we're scrubbed in, and I'm a junior resident, and there's Cooper, Patterson, Ginsberg, Pearson, Goldberg. I mean, like about 6 giants in thoracic surgery, right? So they all figured out, and I'm sitting there cutting sutures where I had to sort of reach like 3 feet away to even see the suture to cut. And so they finished the transplant, and the patient was stable and everything. And then they all just took their gloves off and walked out of the room. And I'm sitting there with an open, and I didn't even know how to close the chest at the time. So I'm sitting and say, wait a minute, guys, you know, like they all just kind of left me. But, you know, again, I was just on cloud nine. I mean, I thought that was just such an amazing thing to witness, you know, and to know that you've been there. You know, there are very few things in medicine today that are huge leaps. You know, all of us were, you know, each of the things that we're doing with all of our advances, they're incremental and remarkable in what we can do today. But that was a momentous leap, really, to when it finally hit me as to what this meant. It also defined my career, right? It was just being in the right place at the right time with remarkable teachers and the opportunity to sort of be part of working on lung transplantation and solving the problems.
When was the first ISHLT meeting that you went to?
The first one was probably 1988.
When it was ISHT?
Something like that.
Yeah.
I think it was very heart-centered. It was a smaller group. Again, you know, being from Toronto and involved with it at the time was sort of a unique experience to learn and to be able to present my work, you know, from the lab and learn at what's going on. I quickly saw it that, you know, as you know, the level of the science wasn't that high at the time, but I quickly recognized that the ISHLT and that meeting is the meeting in heart and lung transplantation, and a very valuable asset to our field, because it brings together everybody who cares about heart and lung transplantation, regardless of whether they're a surgeon, cardiologist, pulmonologist, pathologist, basic scientist. There are very few meetings that have that kind of multidisciplinary, but yet unifocal intent. And I think it's something that we should work hard to preserve as meetings and areas in medicine get so specialized, because the fact that we bring all those minds together is where we'll get the full benefit of everybody's capabilities.
What's your favorite story from one of the meetings that you can tell?
Yeah, that I can tell. There's many I can't tell, I think. Somehow they all have something to do with alcohol for some reason or the other, and I think you know some of them. No, it's a great meeting in the sense that it does take several days. The meeting's always fairly long, and, you know, I like to be involved in it, and certainly probably of any meeting I ever go to, I attend more sessions just to learn than anything else. So, but what I do like is the fact that we've made a lot of friends, and you get to spend time with people that you interact with professionally around the world through emails or meetings, but you don't actually spend time as much as, and this meeting gives you that time, whether it's just chatting in the hallway over a coffee or whether you're having a good dinner together and drinks, but it's time to just sort of just chat and talk about stuff that we all have a passion about. And I've learned so much from so many people, not only about lung transplantation, but about leadership, about medicine, about, you know, all kinds of things that certainly I'm much better for.
What are we going to be talking about 20 years from now?
I think 20 years from now, we're going to be laughing and saying, can you imagine that we used to send surgeons all over the continent, picking up organs in the middle of the night and bringing them back, and we'd put them right into people without modifying them and engineering them. I truly believe that the future of transplantation will be that all organs will be checked and processed and modified and personalized for the patient that you're going to put them into, so that you're not going to just take a slightly used organ and make the best of it in someone else. And I think just like we talk about blood transfusion today and component transfusion, nobody transfuses whole blood. We'll look at it and say, could you imagine, remember those days when we used to just go and flush an organ and bring it in and sew it in? I think that's what we'll be laughing about.
Shaf, thank you for taking the time.
Thanks.
It's been enjoyable.
Thanks.